Okay. Our next speaker is Mir Karasanizadeh. He is a doctor from Tehran. He completed his medical school in Tehran University of Medical Sciences. And since then, he has been working as postdoctoral fellow and pre-residency fellow. He worked as a postdoctoral fellow actually at Mount Sinai from 2016 to 2020 in the Sinai Trauma and Surgery Research Center. In 2020, he then started a two-year fellowship at the Division of Vascular Neurosurgery at Beth Israel in Harvard in Boston. And he has been very active publishing. He's published 34 peer-reviewed journal articles. And he was recently the recipient of the 2022 B Foundation Brain Aneurysm Research Award. Thank you very much, Mir. Looking forward to hearing your talk.
Thank you, Dr. Keller, for introduction. I'm gonna share my screen. Okay, can everyone hear me okay?
Yep, looks good.
All right, before I start, I wanted to thank the department for giving me the opportunity to present some of my prior research from my postdoc days in Harvard. So considering that the topic of middle meningeal artery embolization was recently discussed here in Grand Rounds by Dr. Kellner, I thought maybe I would pick a couple of my papers on this topic, which might be of interest. So these are my disclosures, and parts of this talk have been previously presented in CNS meetings in 2021 and 2022, AANS 2021 and NENS. I also need to acknowledge my PIs at Harvard, Dr. Ogilvie, Dr. Thomas, and Dr. Moore, and the rest of the research team that we had over there. So I will briefly touch on the pathophysiology of chronic subdural hematomas, although I'm sure everyone here is familiar with that. Chronic subdural hematoma, chronic subdural hematoma is thought to start with a traumatic event there in the dura, and a release of blood products in the subdural space, which then trigger an inflammatory response. Pro-inflammatory cytokines can result in formation of a fibrotic membrane, angiogenesis in that membrane results in formation of leaky capillaries that will continuously leak into the subdural space and sustain the hematoma. So surgery is thought to only remove the mass effect and cannot address the root cause, which is this self-sustaining inflammatory cycle. And MMAE is thought to address this root cause through devascularizing these membranes and breaking this cycle. So here on the right, you can see an example of neovasculature forming in the dural membrane, and also on the left, you can see a cotton wool appearance or blushing of the neocapillaries on external carotid artery injection in a patient with subdural hematoma. So there has been a ton of research in the past few years on this topic. I was fortunate enough to be a part of that. I've selected 3 of my papers that I want to present on MMAE. The first one, published in JNS, revolves around study of the morphological and structural changes of subdural hematomas after an MMAE procedure. So we don't really know what happens in terms of the radiologic appearance of the subdural hematoma after we do the MMAE, and what we should expect over time, which has important implications for follow-up of these patients. So this study was designed to study that question. It was a retrospective single-center cohort study. We included upfront MMAE patients from Beth Israel Hospital. So there was a classification for morphologic appearance of subdural hematomas from Nakaguchi et al., developed in 2001. I modified that classification in order to be more inclusive of all types of morphology that we observe. We studied baseline and follow-up head CT scans for all of the patients for the appearance of the hematoma, the density, and the loculations. So here you can see the modified Nakaguchi classification that we came up with. There are 6 types of morphology on this classification. The first type is acute and chronic bleeding. Second type is homogeneous hypodense. Then we have homogeneous hyperdense and isodense. We also have laminar hematomas, as you can see here on this head CT scan. The next type would be separated or gradation subtype, which has an anterior more hypodense component and a posterior left more hyperdense component. So if they mix a little bit on the border, we call it gradation. If there's a clear border, it's called separated. And lastly, trabecular subdural hematomas that are characterized by formation of septations and membranes, and they're usually loculated. We used a 3D reconstruction software for volumetric measurement of the volume of the hematomas, considering the significant limitations associated with just measuring the axial thickness. So here you can see progression of a subdural hematoma over time, and it's being continuously resolved. We were able to include 52 subdural hematomas in this study. I will skip over the outcomes that were not relevant to the purpose of the study. So the main result was that we were able to, for the first time, identify a sequence of morphologic changes after MMAE, which is depicted here in this figure. So we found that hematomas start with early stage morphologies, which are acute and chronic and homogeneous hyper or isodense. Then they progress to separated gradation subtype and then the laminar subtype, which we call the intermediate stage. And they're characterized by gradual resorption and evolution of the blood products. And after that, they progress to homogeneous hypodense subdural hematomas, and then trabecular, and eventually completely resolved. A very interesting finding was that any deviation from this sequence of morphologic changes was associated with 100% chance of need for recurrence of the hematoma and need for reintervention. So this sequence is really characterizing the normal sequence that should be observed, and any deviation from it is an ominous sign. Here you can see an example of this progression in one of the patients that started with gradation subtype at baseline, then progressed to laminar, then became trabecular, and eventually completely resolved after almost 6 months. I also studied the duration of each morphologic stage in order to identify what should be expected in follow-up of these patients. So as you can see, early stage hematomas take on average almost 2 weeks to progress to intermediate stage. Intermediate stage hematomas are sustained for an average of 1 month before progressing to homogeneous hypodense. Homogeneous hypodense hematomas take 1.5 months on average to become trabecular, and then after almost 3 months, the hematoma completely resolves. So if someone were to ask, how long does it take for a chronic subdural to completely resolve after an MMAE procedure? The answer is that it depends on when we receive the hematoma and when we perform the procedure in terms of the morphologic stage. So if it was an early stage hematoma, it would take probably around 6 months. But if it was a later stage hematoma, it will take less. We were also able to identify a few prognostic factors related to morphologic features. For example, we found that early and intermediate stage hematomas tend to have a better outcome after MMAE. We found that the density of the homogeneous hematomas should decrease markedly in the 1 to 3 week post-op period, and if that is not observed, that's an ominous sign. We also observed that hematoma's volume, axial thickness, and midline shift are not correlated with MMAE outcomes, unlike surgery, which they are correlated. And also we observed that loculated trabecular and laminar hematomas, which are thought to be poor surgical candidates, have similar outcomes to other types of hematomas in MMAE. Here you can see an example of a trabecular hematoma that completely resolved 5 months after the procedure. Here we can see an example. Sorry, the previous slide was for a loculated hematoma. Here you can see the trabecular hematoma that completely resolved after MMAE. Our study was also the first study to quantitatively document the transient rise in density of the hematomas after the MMAE procedure, which is actually a proof of concept for MMAE. It proves that the contrast that we are injecting is leaking through those leaky capillaries in the membranes into the hematoma. We also observed that this rises in density is transient and goes back to the pre-procedural levels on the second week post-procedure. Here's an example of this phenomenon. On baseline, the mean Hounsfield unit of the hematoma was 24. 1 day after the procedure, we can see that it has become a little bit more hyperdense, and now the Hounsfield is 33. On post-op day 8, it's even lower than baseline at 14. On this graph, we have depicted the changes of density and volume of homogeneous hematomas over time. Here's the bump in density that I just discussed. Here's the drop in density 1 to 3 weeks after the procedure that is expected, and the lack of this drop is associated with eventual progression of the hematoma and need for reintervention, as you can see on this graph on the right, which correlates with patients who actually required reintervention. You can also observe that volume of the hematoma is not expected to significantly drop in the first 6 weeks after the procedure, and most of the volume resorption occurs after the 6-week mark. So based on all of this, for the first time, we attempted to recommend a follow-up schedule for MMAE patients. So considering that not a lot of volume change is expected in the first 2 weeks, and also the density fluctuates in this period, we don't think imaging follow-up in the first 2 weeks would be helpful. The first head CT scan can be done at 2 weeks. On this head CT scan, we are looking for progression of the morphologic stage of early hematomas to intermediate stage and intermediate stage hematomas to late stage. But we still do not expect a lot of drop in the volume. At the 6-week mark, we can do another head CT. Here we're looking for morphology, so all types of hematomas should have progressed to homogeneous hypodense by now. We are also looking for that drop in density, which should have happened by this point. If not, it's an ominous sign, and then maybe we should keep a closer eye on these patients. And lastly, at 3 months, we can do another head CT scan. By this point in time, we expect the volume in all types of hematomas to have dropped by at least 50%. So I'll move on to my next paper that I want to present. Before that, I'll quickly recap on the anatomy of MMA. As all of you know, MMA has 2 main branches, the frontal parietal branch or the anterior branch, and the squamotemporal branch or the posterior branch. So there are 2 important considerations for every MMA procedure. One is the petrosal branch, which originates near the foramen spinosum. It perfuses the cranial nerve 7 and...
Can I pause you for a second? And can we have discussion around that first paper? Because you brought up a lot of interesting points I think people might want to discuss. And then we can move forward with the next paper.
Absolutely.
Any comments from the residents or students or faculty about that? I do have a few questions myself.
Mir, great work. So I understand you to say that there's a 95% 6-month success rate, more or less.
So
171 days, 90, and only 5% fail. So 95% 6 months success rate.
thank you, Dr. Bellison. So in our cohort, in the first study, the rate of treatment failure or need for re-intervention was around 9%. And that's after an average of 100 days of follow-up.
I didn't get that out of your presentation. I heard you say that 5.4% failure to progress, and they all did poorly, but I guess there must be others who don't do as well on top of that.
Yeah, so I can go back to that slide. So that 5% was related. That 5% was hematomas that did not follow that morphologic sequence that I described.
Right.
And out of those, all of them required reintervention.
And then there's another 4 or 5% who might follow, but they still don't.
Correct.
As well as we'd like.
Correct. Yes.
So basically 90%, 4 to 6 months success rate.
Yes, almost 91%. Yes.
Uh-huh.
Yes.
And how does that compare to the same group that is not treated with MMAE?
So, Dr. Bellison, this was not a comparative study between MMA and surgery, but we also have had that study done. I mean, we did that study at Beth Israel. So the average rate of recurrence for the surgical group when matched with propensity matched comparison was almost twice the MMAE group. I've also done a national level study using the Vizian clinical database that compares MMAE plus surgery compared to surgery alone. So I wanted to present that study here too, but unfortunately due to time restraints, I had to remove it. But on that study, we found that the risk of recurrence of the hematoma is half in the MMAE plus surgery group compared to the surgery alone group. The MMAE plus surgery group had 600 cases, and the surgical group had 6,300 cases.
Thank you.
Mir, did you find any patient or procedural factors that influence the rate of reabsorption or the character of reabsorption?
Yes. As I mentioned before, so some of the morphologic factors had prognostic significance. For example, if the hematoma has early or intermediate morphology, for example, it's acute on chronic, or it's hyperdense or isodense, or separated or laminar subtypes, they usually have a better prognosis. I'm not sure why that happens, but my assumption is that if the hematoma is actually acute or subacute, then there's maybe more active leakage from the capillaries, and MMAE is more relevant for these cases compared to a trabecular or a homogeneous hypodense hematoma in which dura may have already fibrosed the dural membrane, and it may already be in resolution phase.
What I mean is there anything we can do to accelerate the rate of reabsorption? For example, some people have talked about different embolization techniques, better perfusion, bilateral embolization. Did you find any procedural features that accelerated or decelerated rate of resorption?
So on the second and third study that I want to discuss, we looked at some different procedural techniques and variations that may affect the outcomes, although the results are negative. But as I will mention later, it's also very important that what branches we embolize for the MMAE and what embolized material we use. So some think that they can affect the outcomes, but our results are actually contrary to that, and that's what I want to discuss here.
Okay, maybe I'll let you move on to that then. Go ahead.
So as I was saying, the petrosal branch reflux of embolic material into this branch can result in facial nerve palsy, so we have to be aware of that. and the tip of the catheter should always be well past the origin of the petrosal branch. The other dangerous collateral that we should be wary of is the ophthalmic collaterals. They usually originate before the anterior branch of the MMA. And obviously, if the tip of the catheter is proximal to that, the embolized material can result in distal ophthalmic artery occlusion and visual complications. So the background for these two other studies that I want to discuss is that the optimal procedural technique and embolization material for MMAE are not yet well understood. The most common materials that are used are liquid and particle embolics. Adjunctive use of coils is a common practice in some centers, not all centers. So the theory behind liquid and particle embolics is that they can provide a more distal and robust restriction of flow, and that theoretically can result in better outcomes, but there's actually no data for that. And also, on the other hand, they carry a risk of distal embolization into the collaterals that I just described. So it's unclear if isolated use of coils can result in suboptimal outcomes compared to when particle embolization is also performed. And that's what we studied here in this study that was published in World Neurosurgery. So the objective was to compare outcomes of coil-only MMAE with combined use of coils and particles. The second study focuses on the comparison of different branches that are embolized during the MMAE procedure. So currently there are different practices because there is no consensus. Some proceduralists attempt to always catheterize both distal branches in order to avoid any risk of cranial nerve or visual complications. Some try to catheterize both distal branches and the main trunk in order to achieve a higher restriction of flow. And some proceduralists only catheterize the distal branches if there are dangerous collaterals on the pre-procedural angiogram. There's limited evidence comparing these different approaches. The only study that I was able to find so far is the study by Catapano et al. That Dr. Kellner also discussed on his presentation. So they had 25 patients on the distal plus proximal group and 16 patients on the proximal group, and they couldn't find significant difference between the outcomes. So it's unclear if more the embolization of more branches translates into a better outcome. It's unclear whether a distal selective catheterization approach provides better outcomes compared to just catheterization of the proximal trunk. And it's also unclear how the very variable anatomy of MMA should affect the choice of branches. So this second paper published in JNS focuses on this subject. Again, this was a retrospective cohort study in our single center. We were able to include 94 hemispheres in 78 patients in these two studies. So for the first study that focuses on isolated coil MMAE, obviously we grouped the patients into isolated coil MMAE and coil plus particle embolization MMAE and compared the outcomes. The indications for isolated coil MMAE was usually presence of ophthalmic anastomosis, as explained earlier. In one case, it was because of perforation of the MMA. So obviously, we did not want to inject particles into the subarachnoid space in this patient. And also, in another case, it was due to difficulty catheterizing the MMA. Only a very proximal position could be achieved in this case. So we were worried about the risk of reflux into the petrosal branch or more proximal ECA branches. So that's why isolated use of coils was opted for. 12 hemispheres received isolated coil embolization of the MMA. Here you can see that on baseline, there's no significant difference on baseline characteristics, including the hematoma's volume, midline shift. The only difference was the higher percentage of anticoagulant use in the coil-only group, which, if anything, would negatively affect the outcomes of the coil-only group. So the outcomes showed that there's no difference in the need for reintervention changes or the resolution of the hematoma. As you can see here, the percentages of resolution and the risk for reintervention are almost identical. Here you can see an example of isolated coil MMAE in this patient that resulted in complete resolution of the hematoma. So to further discuss, currently more than 96% of the procedures are done with liquid or particle embolics based on a recent systematic review. We think the current practice maybe is because proceduralists theorize that particle embolics can result in more robust restriction of flow, but it should be kept in mind that the significance of this additional flow restriction is uncertain, given that even untreated subdural hematomas have been shown to resolve spontaneously in natural history studies. The other point is that maybe there's more familiarity with particles and liquid embolics because we also embolize the MMA for tumors and dural vascular malformations. But again, it should be noted that chronic subdural hematoma is a different pathology, and unlike dural AVMs or tumors, the blood flow of the MMA is not highly elevated in subdural hematomas, so we may not need that much restriction of flow to achieve outcomes. So based on the current study, isolated coiling can provide enough flow limitation to halt hematoma's expansion and tip the balance towards spontaneous resolution of the hematoma. And this is a significant result because isolated coil MMAE can eliminate the risk of visual or cranial nerve complications. And there's always, in particle embolization, there's always a baseline level of risk because no matter how much precaution is taken, there could always be reflux of the embolic material, as in this example. And also the collateral pseudo-ophthalmic artery may be missed or non-detectable on the pre-procedural angiogram. So in conclusion, for this study, we think that if dangerous anastomosis are observed, isolated coil embolization is a promising option. Further, larger studies in the future can also work on the question that whether isolated coil MMAE can be used in all MMAE procedures and become the standard of choice, which would significantly simplify this procedure and reduce the costs and eliminate the risk of visual and cranial nerve complications. So for the second study, really quick, we categorized patients based on the type of MMA branches that were embolized. First group was proximal trunk only, then distal branches only, and then both. We also categorized them based on the number of branches, so one branch only or more than one branch. And lastly, we categorized them based on whether the dominant MMA branch was selectively embolized or not. So I'm going to skip over the details of how we determined the dominant MMA branch, but briefly we used the Adachi classification system. So here you can see the results. It shows that main trunk only, distal branches only, or main trunk plus distal branch groups had similar outcomes in terms of need for reintervention and resolution of the hematoma. The same goes for the number of branches. So embolization of one branch was similar to embolization of more than one branch. And also the selective catheterization of the dominant branch did not have an effect on outcomes. So these findings are important because catheterization of distal branches are not always feasible because the MMA trunk or branch could be too narrow. There could be a difficult angle. The patient may move, and also repeated attempts to do that may result in anesthesia, higher time under anesthesia or fluoroscopic radiation. It risks perforation of the MMA, and it can also result in vasospasm. So currently, some proceduralists will abort the procedure if distal catheterization is unsuccessful, but this study indicates that distal branch embolization is not a prerequisite for procedural success, and we can still achieve acceptable outcomes with just proximal trunk embolization. And it also seems like embolizing any MMA branch, only one of them, is enough to provide enough flow limitation to halt hematoma's expansion and tip the balance towards spontaneous resolution. Thank you so much. I'll be happy to answer any questions.
Thanks a lot, Mir. Any questions from the resident team or our audience? Yeah, as I'm on there.
Yeah, thanks, Mir. Great studies, and thank you for sharing your results. We typically, when we're thinking of embolizing the MMA, just like with a lot of embolization procedure, as you have mentioned, the theory is the deeper the penetration and the wider spread that is, the more likely you are to get a positive effect. So your findings here are challenging that thought, which is a good thing to be challenged if there are alternative theories to how MMA embolization may work. Do you think that the power of the study was sufficient to show differences between those cohorts, if a difference was present, especially in a procedure that does require a larger number needed to treat to demonstrate the effect?
Thank you, Dr. Shura. Yeah, the issue of power is always an issue in these types of studies because, as you know, in no single center study we can achieve the appropriate power to study this. So the numbers that we observed, it was not like one group was 60%, the other group was 80%, and the p-value was still not significant. The numbers that we observed was that it was almost neck to neck, or even in some outcome variables, even better in like isolated coil MMAE or proximal trunk MMAE. But I acknowledge that limitation. Unfortunately, currently MMAE studies have had low number of patients so far. We are working with University of Pennsylvania doing a multi-center study with multiple centers to corroborate these results.
That's great. The other thing that probably was in your slides, but we didn't get a chance to really look at is rates of complication. We know that one of the reasons in recent years that we've been having a way safer profile with MMA embolization is the selective distal catheterization of vessels away from the high-risk collaterals with ophthalmic or petrosal branches. Did you notice any difference in the three approaches to embolization in the complication rate?
So, yeah, unfortunately, I didn't get a chance to discuss that. So we only had 2 complications in our entire 94 patient cohort. One of them was a ophthalmic artery occlusion, and the other one was an M2 stroke, which was probably unrelated to the location of the embolization. And the ophthalmic artery complication happened in a patient that had proximal trunk embolization, and that was done because the ophthalmic collaterals were not visualized on the pre-procedural angiogram. So that was early in the practice of Beth Israel, when if there was no ophthalmic collateral was observed on the pre-procedural angiogram, proximal trunk was embolized. But over time, the practice evolved over there, and proximal trunk usually was only coiled, and particle embolization was only done in distal branches because, as I mentioned, sometimes these collaterals are not observable on the pre-procedural angiogram.
Amir, how often did the operator have to bail out and do a proximal coil embolization?
So the thing is, in Beth Israel, Dr. Ogilvy and Dr. Thomas's practice, they do not do proximal trunk coiling or embo if distal branch catheterization is not possible. They do it whenever they can. Like it's part of the planned. It's like planned before the procedure to try to embolize the proximal trunk, at least with isolated use of coils whenever possible.
I guess what I'm asking is how often were they not able to get distal selection?
Let me see. I have that number in the paper. I think it was around 20% of the patients.
Yeah, I think that's probably also our experience for any particular branch is 20%, maybe a little less. But it is important then to know, does coil embolization suffice as the treatment? Or do you really have to try to get into the distal branch? So this is valuable information to let us know that it's possible that coil embolization is sufficient.
Thank you, Dr. Kelly.
Any other questions from anybody else? Thanks a lot, Mir. That's a really great body of work you're building there.
Thank you, sir. Appreciate it. Thank you for the opportunity.